So I want to welcome everybody to this briefing and thank you for joining. This is our fourth installment of our congressional briefing series on protecting federal leadership in addiction science and public health. My name is Dr. Diana Fishbein, otherwise known as Denny. Today we're going to focus on a critical pillar of our national response to substance use crises, namely prevention. We all know that treatment and recovery are absolutely essential, but we cannot treat our way out of these crises alone if we want fewer overdoses, less suffering, and a stronger public health system altogether. Prevention has to be central to the conversation. Effective prevention is actually the application of decades of rigorous science to reduce risk and strengthen resilience across the lifespan, supporting healthy development, reducing exposure to adversity, and strengthening families and communities before problems start. So when it's well done, prevention saves lives, it reduces health and social costs, and advances equity. Despite this, body of very strong evidence, prevention remains chronically underfunded and undervalued in our policy discussions. And that's why federal investments matter. It builds and sustains prevention infrastructure. In short, there are 5 ways such funding makes that infrastructure possible. And I'm not going to go into any detail here as the speakers will be touching on some of these topics. But federal funding helps to build core capacity at a local level through agencies like the CDC and SAMHSA and the Administration for Children and Families, HRSA, and others that provide the backbone supports that communities need. Federal funding also supports evidence-based practices in communities so they are not left to, rely on their intuition. Also, thirdly, it promotes equity and national reach, particularly to communities that are facing structural inequities. Fourth, it strengthens cross-sector coordination. It encourages alignments between schools, healthcare, child welfare, juvenile justice, housing, workforce partners, et cetera, et cetera. And fifth, it delivers long-term savings in downstream costs that are associated with a greater need for healthcare and criminal justice involvement, social services. So taken together, these investments are more than just a set of grants. They are the structural supports that allow communities to prevent problems before they escalate. And when funding is sustained and aligned with the evidence, it creates a durable prevention ecosystem. So this briefing is sponsored by the National Prevention Science Coalition to Improve Lives, which is a coalition that I direct for the last 12 years, and many of the folks here that will be speaking are on the board of directors. It's a large professional organization associated or that is devoted to translating systematically prevention science evidence into public health policy. And it's also sponsored by the Addiction Science Defense Network, which is a partner of MPSC. So to preserve the funding for research and evidence-based programs that are so critically needed, we formed the ASDN for an exchange of information and to provide an action network for individuals and organizations that study, treat, and prevent problems caused by psychoactive substance use and other addictive behaviors. Our network includes research societies, addiction journal editors, practitioner organizations, programs engaged in training of scientists and clinicians, and other organizations that overlap with the addiction science community, as well as individuals with lived experience. We are advocating in Congress and with federal agencies to preserve funding for the research that is foundational to our nation's ability to respond to the substance use crises that we have. We're also urging that the federal government reinstate and scale up supports for states and communities to be able to reliably deliver needed programs and services. And we're also informing the public so that they too can understand the importance of urging their own representatives to preserve this life-saving infrastructure. I also wanted to alert you to the upcoming launch of the Addiction Science Under Siege report, which will be released on May 7th when we have a webinar that's being coordinated by the Drug Policy Alliance. The report presents findings from an in-depth analysis of how federal actions have impacted infrastructure that supports research and treatment and prevention services. So please do keep an eye out for that announcement. I also want to mention our next briefing will be on the importance of community engagement to reduce substance use and promote community well-being. We don't have a date for that yet, and when we do, you'll receive the announcement. It will likely be towards the end of May. And I want to introduce to you Paige Marsland, who is our moderator today. Dr. Marsland is a postdoctoral researcher at Binghamton University in the Verodian Lab, where her work focuses on understanding how adolescent alcohol exposure shapes neural circuit function across the lifespan. Along with her bench research, Paige is the founder of Bite Size Neuro, which is a really cool science communication initiative to increase science literacy in schools and in community organizations. Through Bite Size Neuro, she translates complex neuroscience concepts into accessible content for general audiences with particular focus on engaging students in scientific thinking and inspiring an interest in research and science. Now, our first speaker, a keynote, will be Dr. Zilli Sloboda, and I'm not going to introduce her now because Paige will be introducing her. And then our speakers, our speakers are shown here. This session brings together leading experts in prevention, epidemiology, public health, economics, and policy to talk about what prevention science tells us, what is at stake, and how prevention can and must play a larger role in addressing substance misuse and addiction. They'll talk about why prevention is not only cost effective, but morally and scientifically imperative, and what policymakers can do to ensure that prevention remains a core component of federal action. Just a few housekeeping tips. Feel free to message each other in the chat. I see you're already doing that. That's great. We won't be able to track them, but we do look at them later to see if there are important resources and links and other information that we want to keep and reshare. So please feel free. If you actually have questions for the speakers, however, you must submit them to the Q&A, and then they will address as many as possible, either in writing or at the end verbally. The briefing and all, the recording and accompanying resources and slides will appear on our website a few days after the briefing. So again, we thank you. It's my pleasure to begin today's session on the promise of prevention. And I'm going to bring Paige now into this so she can introduce Zilli Sloboda.
Hi, thank you very much, Denny. So Dr. Sloboda is president of Applied Prevention Science International and a co-founder of both the US and European Societies for Prevention and Research. She's been trained in medical sociology and epidemiology. She spent 12 years at the National Institute on Drug Abuse, NIDA, ultimately directing the Division of Epidemiology and Prevention Research. Her work spans substance use, epidemiology, prevention workforce development, and the translation of research evidence into international policy standards, including contributions to the UN Office on Drugs and Crimes Global Drug Prevention Framework. Thank you, Dr. Sloboda.
Oh, thank you very much, Paige. Can you all hear me all right?
Yes, we can hear you.
Okay, great. Thanks, Paige. Had some computer problems this morning, so I hope everything's good. First of all, welcome, and so nice to see a lot of familiar people in the audience. I really appreciate that. I think this is an important effort that we're making. My presentation today is more aspirational, presenting a vision that's something we all want to focus on as we move forward in improving the service delivery to people who need it in our country. Next slide. Okay, thank you. So I think understanding the natural history of a health condition, the epidemiologists in the audience probably will understand this a lot. Looking at it from onset to outcome without an intervention is vital for developing effective prevention interventions, treatment programming, and just improving the overall health conditions and public health. It guides the design of clinical research and it establishes benchmarks for treatment success and prevention success. So we have those measures. Next slide. This understanding then allows us to determine what services are needed to address a health problem, such as substance use, from preventing the onset of substance use and its progression, and to treat those affected through recovery. Next slide. Such a range of services then suggests the need for a national, comprehensive, and integrated service delivery system that supports this range of services from the community through the state level and overseen by a national government organization. Such a system should be based at the community level, offering a range of evidence-based services that are delivered by trained and certified professionals and supported by a monitoring and evaluation system to enhance the quality of services being delivered. Next slide. And our focus today, of course, is in prevention. Next slide. So epidemiologic studies show that there's no single pathway to a behavior such as substance use. These studies indicate that it is the interaction of the individual and his or her personal characteristics, their genetics, their temperament, their physiology, the interaction between them and their micro level environments that includes family, school, peers, faith-based organizations, workplace for us who are older, and their macro level environments. And you'll see that the usual macro level environments that you've seen before, but I've added climate change because I think that climate change is going to have a big impact on our communities in the future. So these interactions, oh, sorry, could you go back? It's like these interactions then shape our behavior. They shape our attitudes, our beliefs, our perceptions of norms in our communities. And so they also encourage or can support the engagement in risky health behaviors such as substance use. And Dr. Riggs will be talking more about this in a while. I just love his slides. They're really, really informative, I think. Now the next slide. Over the last 40 years, the field of prevention science has matured to provide direction for our prevention efforts. In what ways does prevention science inform prevention practice? Prevention science informs how prevention practitioners assess the problem they wish to address, including inventorying relevant available services in their community. Once the problem is defined, prevention science provides guidance to match the needs of the community with evidence-based prevention programming. And finally, it helps the prevention practitioner monitor the implementation of those programs and to document at least that the achievement of short-term outcomes of the program. Next slide. And although prevention research, through prevention research, we have available today prevention programming that has demonstrated success through rigorous research to address each point of vulnerability and risk that I noted earlier in this chart. And you can see that those interactions, because the points of intervention for each of those arrows. And I think that's really significant that we've really reached that stage in our research efforts. And the translation of that for each community, of course, presents a real challenge to all of us. Next slide. Currently, the delivery of evidence-based prevention programs is not uniform across communities in the United States and around the world. This is drawn from a paper that Denny and I had written that's published in 2023. What it does is it pulls out a delivery system to support prevention program at the community level. And it includes many of the components that I talked about before, including monitoring what's going on, having trained and certified practitioners who are providing the information. And I would love to see a range of all addressing all areas, the micro and macro level, with our evidence-based programs that we have. Next slide. This graphic I'm sorry, the system, however, requires guidance. And this should be a living thing that we constantly are updating our information back and forth, going to community practitioners, but also for getting information back from their experiences to inform research, for instance. We haven't done that well enough, I think, over the last few, that's my opinion. Anyway, you can see the diverse groups, that there are probably other groups that you probably could think of that might serve to inform this delivery system that I presented earlier. Next slide. And I think this is important. I think the prevention technology transfer centers are really important for prevention programming in the United States. And I'm very happy that their funding was continued. And this graphic shows the benefit cost ratio of evidence-based programs. And you'll see, again, across the spectrum of programs, there's clear gain in investing in these programs. And the proposed delivery system that is recommended should assure that these and other evidence-based programs are delivered as they were designed by certified prevention practitioners. And finally, talking about aspirational, this is my image of having a comprehensive service delivery system across the country and linking communities and sharing experience, and so that we improve the lives of our children, their families, and our communities. And our panel is going to highlight some of the key points I just covered. Thank you very much.
Thank you very much, Dr. Sloboda. And just a reminder to everyone, please put your comments and questions in the chat, and we'll keep track of them as we go, and we will answer questions at the end during the Q&A session. Next up, we have Dr. Richter. Dr. Richter is Senior Vice President of Prevention Research and Policy at Partnership to End Addiction, where she leads the organization's national prevention research and policy agenda. Her work focuses on advancing earlier approaches to substance use prevention, with particular emphasis on developing actionable policies and programs that protect young people and promote healthy development.
Thank you.
And Dr. Richter, you're still muted.
Okay. Do you see my slides okay?
Yes, we can now. Thank you.
Excellent. Thank you so much, Paige and Denny. I'm so honored to be part of this panel. I'm Linda Richter. I lead the prevention research and policy work at Partnership to End Addiction. So I'd like to start by addressing the seemingly simple question of what exactly are we referring to when we talk about prevention. So when thinking of prevention, people often think of school assemblies or drug education, and prevention is certainly all the things that you see here that directly relate to protecting kids from the substances that they're most prone to using and misusing: tobacco or nicotine, alcohol, marijuana or cannabis, and controlled prescription drugs. But prevention is also so much more than that. It encompasses actions and interventions that on their surface may not seem to have to do so much with substance use itself, but rather the conditions that help kids grow up healthy and safe. So these are things like strong families, safe communities, and access to care, which all play a role. So in short, prevention isn't just about stopping substance use, it's about supporting healthy development and safe and protective environments for young people. So what does the research show to be effective in preventing youth substance use and its consequences? Well, the research is clear. Prevention must start early, before substance use begins. Looking at these federally funded data from SAMHSA, we see that the vast majority of 12 to 13-year-olds are not using any substances, but those numbers of non-use go way down once kids hit their late teens and 20s, underscoring the need for early prevention. These federally funded data also show how much timing matters. Starting before age 18 dramatically increases addiction risk compared to waiting until adulthood. So even a few years of delay makes a major difference in the likelihood that a child will develop a substance use disorder. We like to use this colorful river metaphor to symbolize a proactive, early, upstream approach to prevention. So instead of reacting to problems after they occur or downstream, we want to create the conditions that prevent them from occurring in the first place. To come back to our colorful water analogy, risk factors build over time, like a cascade throughout childhood development. So early adversity can lead to later behavioral problems that, if inadequately addressed, can result in substance use problems in adolescence and beyond. But the opposite is also true. Protective factors build through each stage of development, leading to a cascade of prevention. And throughout, one of the most important protective factors that we see from the research is for a child to have at least one trusted adult in their lives. So ultimately, effective prevention comes down to this balance, reducing risk factors while bolstering protective factors. Again, even one strong protective factor like a trusted adult mentor, resilience, a strong sense of purpose or mattering for a child can really help offset the effect of multiple risk factors. And while we might not be able to change a child's family history of addiction or undo adverse childhood experiences, we can support young people in these ways to help tilt the risk protective scale back in their favor. And the good news is that this framing of prevention works. We've seen major declines in youth cigarette use over time, and we did this through smart policies, educating people about the harms, and generally denormalizing smoking. This is one of the biggest public health success stories, and one we can and should replicate for other substances. Federally funded data from the CDC show that vaping rates have declined significantly since their peak in 2019. And like cigarettes, this occurred not because we scared kids, but because of effective prevention strategy and meaningful policies. How about alcohol? National data funded by the National Institute on Drug Abuse show a steady decline in youth drinking over the past few decades, with more than half of 12th graders in 2025 saying they never tried alcohol. These same federally funded data show that although youth substance use rates are definitely higher than we'd like them to be, it's a minority of students who report using any of these substances, alcohol, nicotine, marijuana, in 2025. None of these bars have hit 50%. And this norm of not using has been trending upward for a long time. This is not a miracle or a coincidence. It reflects important advances in prevention science over the past few decades and its broad application in schools and communities across the United States. But despite this very good news, the picture remains bleak for young people who do use substances. And that's because the types of substances that are available today are more potent and dangerous than ever before. Think about nicotine vaping. Although overall rates are certainly lower now than they were at their peak, kids who still vape tend to do so intensely and frequently, with about 30% of high school students who vape doing so daily. And that's largely because the nicotine content in vaping products have been increasing dramatically, making them extremely addictive and difficult to quit using. And by the way, this terrific infographic and the data supporting it are from our colleagues at the Stanford Reach Lab, which is funded largely by federal grants through NIH to provide essential research and free, credible prevention resources to communities across the United States. Drinking. Although the data are encouraging, kids who drink do so more frequently and intensely than adults do, often binge drinking with the goal of getting drunk or wasted. And as is true of all substances, young people who drink are about twice as likely as adults who do so at the same levels to meet clinical criteria for an alcohol use disorder. So the risk for kids is higher. How about marijuana or cannabis? Every year, the potency of marijuana products is significantly stronger, with increasing doses of THC, the psychoactive and addictive ingredient in the cannabis plant. Data tracked by the federal government show a quadrupling of THC potency over the past 25 years. Some marijuana products that are favored by young people today have upwards of 90% THC. And this higher concentration of THC in marijuana products is associated with a whole range of severe physical and mental health outcomes for kids. And these pictures just give a little sense of how bad the targeting of kids has gone. It's really hard to fault them for being drawn to these products or for thinking that they can't be all that harmful if this is how they're presented to them. And then there's fentanyl, which makes casual use of prescription pills a potentially deadly prospect. While adolescents don't typically seek out fentanyl intentionally, they're introduced to it unknowingly when pills are laced with it and obtained through dealers, social media platforms, or the dark web. So given this mixed picture, less overall use among young people, but higher danger for those who use, what does this mean for policy and practice? Well, first we need to invest in comprehensive research-based primary or upstream prevention, not just for substance use, but for the full range of unhealthy behaviors we'd like to prevent and for the healthy behaviors we'd like to promote in kids. We need to keep in mind that prevention is more cost-effective than treatment, but it is consistently undervalued and underfunded, as Denny mentioned at the start. Second, the policies we have matter, supporting psychoeducation, screening, and early intervention in healthcare and school and community systems, and supporting families and communities so that they could provide healthy, nurturing environments for their kids are essential for reducing risk. Reducing youth access and use requires regulating commercialized markets in a way that prioritizes young people's health and safety. This means adequate funding and support for the federal agencies that are charged with regulation and enforcement to ensure objective, science-based approval processes of nicotine, THC, and psychedelic products that are sold for medicinal or reduced risk purposes. And it means much less industry influence over these decisions. And as you saw in the prior slides, and we'll see throughout this session today, robust and credible data collection is essential to track trends, emerging threats, successes, and topics that warrant more vigilance. So to tie this all together, we at Partnership to End Addiction love the Swiss cheese model. So it essentially says that prevention works best when it is layered across families, schools, communities, and policy. No single strategy is enough to prevent the transmission of all risk factors to young people, but together, when layered one on top of the other, they create strong protection for young people. So finally, here's my contact information and Partnership to End Addiction's website. I really appreciate it. Thank you very much for having me. I'll stop sharing.
Thank you very much,
Paige.
Dr. Richter. Yes, that was such an interesting and excellent presentation on how prevention does work, and we really need to continue supporting prevention. Next up, we have Dr. Riggs. Dr. Riggs is the Executive Director of the Colorado State University Prevention Research Center and co-director of the Colorado Workforce Capacity Center, where his work bridges developmental neuroscience research to real-world prevention practice using family-focused and school-based interventions to prevent adolescent behavioral health problems, including substance use. Thank you, Dr. Riggs.
Thank you, Paige, for the intro, and thank you, Denny, for putting this together. And thanks, everybody, for joining us in your investment in this topic. I'm really excited to talk about the interface of neuroscience and prevention and its implications for practice and policy. Okay, so I am a prevention scientist, and one of the things that people in my field have done a really good job of over the past 30 to 40 years is really developing and testing interventions that can address issues like substance misuse, violence, risky sexual behavior, among many other challenges before they emerge. We can prevent these things from happening. And a lot of these programs are efficacious when they're implemented in highly controlled randomized trials. Other programs are very effective once they're implemented in the real world with real communities in real circumstances. And so you can find a lot of these evidence-based programs on registries that include the Blueprints for Healthy Youth Development and the Pew Results First Clearinghouse. And what policymakers and community partners can do is they can go to these resources and identify which preventive interventions are going to be most effective for their own community's unique culture and context and constituents. So the Washington State Institute for Public Policy has gone one step further and said, hey, not only are these programs effective, not only do they work, they're also sound fiscal investments with really nice benefit to cost ratios, which make them excellent candidates for scale up at the local, state, maybe even the federal level. So we know that our preventive interventions work, that they can work when they're implemented well. We also know that they can save communities money. But what I'm here to talk mostly about today is that we also know how many of them work and when to implement them developmentally for maximal impact. So on this slide that we have here, I have a figure that shows when these health behavior problems typically occur. When in development do they happen? And what I'd like to point out to you all, and I hope this is a take-home message, and is that every single one of these behavioral health challenges that I have on this slide, including substance use, mental health challenges, even eating disorders, they have a peak onset before the age of 22. So what that tells me, and I hope this is what it tells you as well, is that if we want to prevent the majority of these problems, we need to start early in life. We need to start in adolescence. And I'm going to show some data a little bit later that says we can even start in early childhood. All right. Now, one of the interesting things about prevention is that we don't actually focus on the developmental outcomes themselves. What we focus on are those risk and protective factors that Linda referred to earlier. So these are the predictors or precursors of these health behavior challenges. Risk factors are the factors that put a young child at risk for the development of a poor health behavior outcome. And then the protective factors, they protect young people from the effects of those risk factors. And what I have here on this slide is this is a non-exhaustive list, of course, of risk and protective factors. And many of these risk and protective factors are specific to specific periods in development. So for example, adequate prenatal nutrition is a protective factor that's specific to the prenatal period. But knowing this, we can time our interventions to those developmental periods if we would like to. Now, other risk and protective factors, some other risk and protective factors, they can span developmental periods, which make them they make them nice targets for our preventive interventions across the lifespan. And one of those protective factors is brain development and associated neurocognitive processes. So what I'm going to, so let's talk a little bit about brain development. So there are two really important areas of the brain that are for our conversation today. One is the limbic system. Now, the limbic system is a very primitive part of our brain, and it lies deep inside of our brain and includes structures like the nucleus accumbens, the amygdala, ventral tegmental area, very fancy names that you don't need to remember for today's conversation. But what is important to remember is that the limbic system is the brain's gas pedal. So it's the more impulsive part of the brain. It drives motivation. It drives emotional impulses, and it's really important for seeking rewards, whether those rewards be natural rewards or even artificial rewards like substances. Now, the limbic system, although it's the more impulsive area of the brain, it did evolve for a good reason, and it really evolved to ensure our survival by getting us off the couch and pursuing things that help us survive, like food and relationships and those types of things. Now, the second part of the brain that we'll talk about today is the prefrontal cortex. Now, the prefrontal cortex is the brain's braking system. It's the adult in the room, okay? It inhibits impulses, especially those that are unhealthy impulses, in favor of long-term healthy plans. It pays attention, it evaluates consequences, it problem solves, plans for the future, things like that. And all of these processes that help make us most human, they're referred to as executive function, generally speaking. It's a term that's becoming more and more, you may have heard of it. It's becoming more and more well-known. Now, there's a developmental piece to this, though. And And that is that the limbic system of the brain is fully developed by the age of 13. So young people, teens, are very capable of having big emotions. They're very sensitive to rewards, right? The challenge, though, is that the prefrontal cortex of the brain is not yet fully developed. It's still under construction. And so that means that the braking system is still developing. And you see all of the things that can happen during this window. You see these peaks in the onset of health behavior problems occurring within that window. So it's this developmental reality, this neurodevelopmental reality, not moral failing, not character flaws in people that place them at risk for taking risky behavior, making risky behavior, and having this be a period of health behavior risk. All right. That all said, there's good news. So executive function is modifiable, and it can be strengthened by those preventive interventions that are on those registries that I referred to earlier on. So we can move the dial on executive function. And here are a couple of examples of evidence-based programs that have done just that. So the first one is the Incredible Years. The Incredible Years is actually a program that focuses on teachers and helping teachers create and cultivate a climate that is where young people feel emotionally safe to be able to regulate their emotions, to be able to problem solve with their peers, to be able to communicate well with their peers, and practice resilience and social and emotional learning. And Sybil Raver in 2011 published a study that young people who were in Incredible Years classrooms, compared to those who weren't in Incredible Years classrooms, increased in their inhibitory control and their attention. So two very important executive function skills. And that those executive function skills translated into future gains in social and emotional learning and academic readiness, both of which are protective factors for substance misuse. A second study is one that I conducted with some of my colleagues at Penn State University and the University of Southern California that looked at the Promoting Alternative Thinking Strategies curriculum. Now, this is a teacher-delivered curriculum that is based explicitly on the neurodevelopmental theory that we've been talking about today. And this program teaches young people how to regulate their emotions, how to communicate effectively with their peers, how to solve problems, how to be socially and self-aware. And what we were able to demonstrate was that PATHS kids, compared to non-PATHS participants, increased their inhibitory control, an important executive function, which then predicted future decreases in externalizing behaviors, which are acting out and aggressive type behaviors, as well as internalizing behaviors that are kind of like sadness, anxiety, things related to depression. And we know that both externalizing and internalizing behaviors co-occur often with substance misuse and oftentimes predict substance misuse. And then a couple of years later, Karen Bierman and some of her colleagues at Penn State University replicated this finding with a preschool version of PATHS. So they implemented this program in Head Start programs and called it Head Start Ready. Again, they found that kids in the Head Start Ready program increased in a global measure of executive function, and that was associated with increases in school readiness, a protective factor against substance misuse. Now, we haven't had any research that's tested the effects of middle school and high school substance use prevention programs, at least that I'm aware of, that have been able to promote executive function. That doesn't mean that it can't do that. It just means that there haven't been any studies that I'm aware of that have shown that. However, we do know that programs like Botvin's Life Skills Training, which is among the most evidence-based of evidence-based programs, it works because it increases resistance skills that require inhibitory control. It increases emotional coping, planning, problem solving, decision making, all of which fall squarely under the umbrella of executive function. So we know that it is possible to promote brain development in the areas of the brain that protect young people from substance misuse. And here I'm talking about executive function and how it relates to the limbic system. But that the developmental timing is really key here. So what we can do is we can work with young people by implementing programs like PATHs, like the Incredible Years, like Head Start Ready, before they enter into that period of relative developmental risk, between that period in which the limbic system is fully developed and the prefrontal cortex is fully developed. And then we can support that development, that healthy youth development, that brain development during those periods of increased vulnerability by continuing to implement evidence-based programs like Botvin's Life Skills Training, the Family Checkup, the Blues program, other programs that we know are evidence-based and can support young people and decrease the prevalence of things, not only substance misuse, but things like mental health challenges, violence, and actually and improve and promote academic development. So thank you all for having me here today. Sorry about the technical issues. I do really love talking about this stuff. So if you'd like to continue the conversation, please feel free to reach out.
Thank you very much, Dr. Riggs. Next up, we have Dr. Graham. Dr. Graham is a principal research scientist at RTI International and president of the Society for Prevention Research, whose work focuses on community-based research on substance use prevention, violence reduction, and health equity. He currently leads family strengthening interventions in the HEAL Prevention Coordinating Center, a multi-project portfolio targeting opioid misuse among older adolescents and young adults. Please welcome Dr. Graham.
Good afternoon, everyone. And I want to thank the previous presenters of setting up what I want to talk about today. Also, thanks for the introduction. And Denny, thanks for NPSC, ASDN inviting me out today. I want to spend the next 10 minutes or so where we're going to explore what I believe are some of the important questions in prevention science. And the one that comes to mind first is, why do some prevention policies work brilliantly in some communities and others fail completely without explanation? And for me, the answer lies in four interconnected pillars. How well a policy accounts for cultural differences, how well it's rooted in community context, whether it's designed to shift systems rather than individuals, and whether it's targeted to the places where risk actually occurs. Before we talk about the solutions, though, let's anchor ourselves in why this work is so urgent. And you've seen this in the previous presentations, but over 90% of adults living with addiction begin using substances before the age of 18. And that tells us that the critical window for prevention is childhood and adolescence, not adulthood. Substance misuse costs the country over $442 million annually, and that continues to increase. But we also know that there's a return on investment for every dollar spent on evidence-based prevention. Research shows 4 to 5% dollar return. So for me, prevention is far more cost-effective than treatment, and particularly treatment after the fact. And these numbers really set the stage for why getting our policies right and how we deliver strategies is going to be important to move us forward. So prevention science has evolved well past giving out pamphlets, even talking about DARE and demystifying why DARE does not work. But today the research points clearly to what I think are 4 pillars or framework that I want everyone to consider. The first is cultural differences. Prevention must be adapted to the values, norms, and lived experiences of the communities it serves. And then community context. Effective prevention is embedded in local social ecosystems, not imported from the outside. The third and most challenging is systems change. So real lasting change requires us reforming the policies, funding structures, and governance systems that shape behavior at risk. And then place-based strategies. Risk is not evenly distributed. So prevention resources must be targeted where risk concentrates geographically. And I believe these are not four separate approaches, but they must be thought about how we can apply them simultaneously in the places of most need. So let's begin with culture and why it matters so profoundly with respect to prevention. Protective factors vary significantly across ethnic and cultural communities. And for example, the concept of collectivism in minority communities, which is a deep prioritization of family loyalty and interdependence, is a powerful protective factor that a culturally adapted program can leverage. But a generic program that only focuses on individual decision making may actually undermine that particular protective factor. Mistrust of institutions is another critical variable. Communities with histories of structural racism, over-policing, and medical exploitation, as an example, will not engage a prevention program just because it's evidence-based. Trust must be earned. And data is compelling. Research from NIDA, for example, suggests that culturally adapted programs are much more effective in reducing the initiation among minority youth compared to non-adapted programs. And in community-based participatory research practices where community members are active partners in program design, almost triples long-term program sustainability. And then what are the policy implications here? I want folks to really think about considering cultural adaptation as a part of every funded prevention program, making sure services are delivered where they most need to be delivered. So the second pillar is about community context. And this is really where the ecological model becomes essential. Profit Bender's ecological model reminds us that an individual person is nested within layers of influence, family and peers, school and community institutions, and the broader policy and social environment. So prevention that addresses only the individual or only the family misses the larger ecosystem. And so what does community fit look like in practice? It means conducting things like asset mapping, understanding how to build trust, but also the importance of using tailored local data to make sure you're addressing the issue. One of the things I want to overemphasize is also the importance of co-design. And what I mean by that, co-designing with youth and families, not just delivering program, but really having them as an integral part of that development is a part that often is misused and or completely overlooked. And so for me, as we were thinking about the development of policies, this becomes a critical point as we move forward. So pillar 3 is probably perhaps the most underutilized, and that's systems change. So individual prevention programs, no matter how well designed, cannot overcome environment shaped by harmful policies. So system changes must shift the rules of the game, so to speak, that we understand how these interact with one another. At the macro level, we're talking about federal and state policy. Things like block grant, SAMHSA's block grant requirements or minimum age drinking requirements, or even cannabis and opioid regulations. These set the baseline environment for young people and young people in the country. And so understanding that relationship is going to be key in terms of how we think about developing these strategies. At the meso level, specifically around institutions and organizations, we need to think about school district policies, healthcare integration, and routinely screening for substance use throughout the life course, even in thinking about employee assistance programs that are aligned with prevention science. And then at the micro level, we're talking about local ordinances. We're thinking of alcohol density policies as an example, but also parental monitoring, education, and also thinking about how do we sustain youth development funding. Each of these are key insights, but they don't work separately. And so as we are moving forward, the other key word I want folks to think about is these things are interrelated and interconnected. So the fourth pillar is place-based strategy. And this is where geography meets equity. And we know that substance use risk is not randomly distributed. It concentrates in specific neighborhoods, along specific corridors, near specific institutions, and so prevention resources should be allocated accordingly. I mentioned earlier alcohol outlet density as an example, but zoning policies that limit the concentration of substances for alcohol retail particularly can increase outcomes significantly. safe routes and expanded school safety zones, reduce environmental exposure, and then investment in green spaces and parks, understanding the role of built environment in terms of reducing risk. And then affordable housing policies matter deeply. Housing instability is a well-documented risk pathway to adolescent substance misuse. And so when we stabilize families, we protect children. And then place strategies are most powerful when they are embedded in communities using local data to really drive those selections. So what happens when we bring all four of these pillars together? I think the evidence is striking. A single intervention can reduce substance use up to 12%, but cultural adaptation almost doubles those effects. And then when these four pillars are integrated, almost 52% reductions. And thing I want to make clear here, it's not necessarily incremental. When you do these four things together, you have much better outcomes. So this is the promise of integrated equity-centered prevention, and it's backed up by evidence and looking at things like prevention science literature and also SAMHSA's strategic prevention framework meta-analysis as an example of that. Not advancing, sorry. Okay, here we go. So what does this mean for the field? For direct practitioners, let's start by conducting cultural humility self-assessments before you select or adopt any program. You can use things like SAMHSA's community asset mapping tools, but make sure youth voice is built into your program's adaptation processes. Not added at the end. I want folks to really think about how we involve communities who are being impacted by these issues at the front, not the back or tail end as an afterthought. And then we also need to track your outcomes with disaggregated data by race, zip code, and risk factors. For those on the policy advocacy side, push for cultural competency standards in all state and federal prevention grant requirements. Advocate for place-based funding formulas tied to poverty indices and risk data, and really champion systems mapping as a required step in coalition strategic planning. And then last, I want to think about how do you promote equity impact assessments before any new prevention policy is implemented. And I don't really think these are abstract ideas. I think they're pretty practical and actionable. And by doing them, we can begin to shift your organizations to really think about these things more holistically. So in closing, a couple things I want to share. Prevention works, and it works when it's built for the communities it serves. The science is clear, but prevention only works at its full potential when it's built for these communities, when it honors culture, when it grows from community-based community roots, and when it reforms systems, and when it targets the places where risk is real. The promise of prevention is not just fewer young people using substances. I think it's communities equipped with the policies, programs, and practices that create conditions for every young person to thrive. And as I think about, Denny asked, what is our call to action? I hope folks leave today and advocate for integrated equity-centered prevention frameworks, both in your organizations and your coalitions and in your legislative priorities. And so I am excited to be a part of this group to really to help promote that we need to think about how all these things fit together. We have to move beyond just thinking about them in silos and understanding that prevention programs are important, but policies really create the conditions for sustained long-term both growth in individuals and communities, but also reductions in risk and also the outcomes of interest. With that, again, I want to thank Denny and others for inviting me, and hopefully this puts in context how we think about this framework in delivering effective prevention policy. Thank you.
Thank you very much, Dr. Graham. I think your presentation really emphasized how we need to integrate prevention across all areas and aspects of our communities and systems. And I think it really shows how prevention really is effective when we consider all of these together. Our last speaker is Dr. Roman. Dr. Roman is a senior fellow and director of the Center for Public Safety and Justice at the University of Chicago, where his research spans the economics of crime policy, cost-benefit methodology, and the intersections of justice systems with the public health and substance use. As a fellow of the Academy of Experimental Criminology and co-chair of the National Prevention Science Coalition, he has advised federal agencies, state and local governments, and foundations on evidence-based justice and prevention reform. Please welcome Dr. Roman.
Thank you all. Thank you for the kind introduction. This has really been fascinating. So I feel like I'm about to say something that is the wrench in all of this and just take all of this to a totally different perspective. So I hope you'll bear with me. What I'd like to do is to talk about the ongoing crime decline in the United States that is very much underpublicized. So this may actually be new information for some folks.
John, we can see your next slide.
Okay.
I think you need to change monitors, perhaps.
Yeah. Let's give it a try.
Yeah, there you go.
How's
Yep.
that?
Thank
All right. Yeah. Happy to do it. So what I want to do is talk about how investments that in the American Recovery Plan Act, ARPA, over the early and middle and ongoing part of this decade, served as a causal mechanism to substantially reduce crime and drug use in the United States. So let me just say a little bit about the historical crime trends, the effect of ARPA on crime, and the effect on drug use. So just to center everybody on the historical patterns of crime in the United States, the blue line is property crime rates for the United States as a whole by year from 1960 to 2025. The orange line are the violent crime rates. And what you take away from this picture is property crime really peaks in the 70s, stays high into the 80s, and then has declined steadily almost every year since about 1990. Violence in the United States peaked later into the early 1990s and has declined in fits and starts until about the middle of last decade when it really stayed steady. What this sort of hides is what's happened over the last 5 years. What you can really see when you overlay homicide, murder on top of violent crime rates, so violent crime here is in red, the homicide rate is in blue, is that there's this massive spike in violence around the beginning of the pandemic that persists for a couple of years and then declines rapidly. Another way to look at that is to show just the homicide rate over the last 20 years from 2025 to last year. We don't have official data on 2025 yet, but I'll talk about it in a second. And what you see here is this long-term decline continues until about 2014. Homicide in America was actually increasing from 2014 right up until the pandemic. It was actually up about 20%. And then it spikes in 2020. This 1 year change from 2019 to 2020 in homicide of about 30% is by far the largest 1 year increase in homicide or in any crime category that we've observed since we started keeping official national statistics in 1960. Just an incredibly violent year. That homicide rate stays high in 21 and 22 and then declines. There's an 11% decline in homicide from 22 to 23, 15% from 23 to 24. So before we dive into how crime has declined, I just want to point out that a lot of what was driving this spike in homicide is almost entirely gun homicide, and it's almost entirely a function of drug markets and violence that spilled out from them. If you look at this graphic from a study in Philadelphia, what you'll see is that the 10 census tracts with the highest rates of drug arrest are in red, and every other census tract in the city is in orange. And up to the start of pandemic, they contributed equally to the amount of homicide in the city of Philadelphia. Then the COVID pandemic hits, and you'll see the red homicide within just these 10 census tracts in Philadelphia explains a just hugely disproportionate amount of the increase in violence. So the homicide spike was about drug selling and everything that goes along with, and all the violence that goes along with that. And the crime decline is also in large part about changes in those drug markets, improvements in them. Now, here's the 2025 story. What you see here is all 9 categories that the FBI tracks. On the left side are the violent crime categories: overall violent crime, murder, rape, robbery, aggravated assault. They are all down substantially from 24 to 2025. And then on the right are the property crime categories. They are also down substantially from 2024 to 2025. These are huge numbers, but even this hides the magnitude of the ongoing crime decline. If you look at the change from 2023 to 2024, what you'll see is that all 9 categories declined. That's only the 10th time in 65 years that has happened, that the crime decline has been that widespread. If you look at the change from 2024 to 2025, not only do all 9 crime categories decline in that year, but in 7 of the 9 categories, it is the largest decline that we've ever measured. And in larceny, it's the second biggest, and rape, it's the third biggest. So this crime decline went from a homicide decline, a gun homicide decline, to an every kind of homicide decline. And it's not just that all categories of crime are declining, it's occurring everywhere. This is a list of 35 major cities in the United States, and all but 3 have experienced a substantial decline in homicide over the last 6 years. So this is a decline that is happening everywhere in every type of crime. So when we look for an explanation for why this is happening, we have to look to a national explanation. I see a lot of mayors and police chiefs saying, we did this policy change, my police did this, we implemented this strategy. All of that is true. All of that contributes to the decline. But the big picture is that we spent $350 billion on ARPA across the country to state and local and tribal and territorial governments. And we gave them really vague instructions for how to spend that money. Just build strong, resilient, and equitable recovery. And what they did with that funding, well, first, I just want to give you a sense of $350 billion, how big that is, right? What was the scale of this investment? The scale of the $350 billion over this 4-year period is almost 2/3 as much as all of the spending on police and courts everywhere, states and local governments, during the same period. It's like we increased the capacity of state and local governments by 2/3. Now, the problem that it specifically solved in the measure we use to see the effects of all this is that in 3 months at the beginning of the pandemic, from March to May, more than 1 million local government jobs were lost. This is equivalent to losing the entirety of the active duty military personnel in the United States in 3 months. ARPA was introduced. The funding really ramps up in 23 and 24. All the money had to be obligated at the end of last year. All of it has to be spent by the end of this year. What did they do with the money? What they did with the money was they replaced lost state and local revenue, and mainly what they replaced was people. So I'm going to show you a slide in a second to show you what this decline and recovery looks like. But what happened here was the ARPA money was used by state and local governments to hire teachers and counselors and clinicians and local police and people who manage grants that fund local community-based organizations. And we think that this explains the crime decline in large part, not only because of the size of the investment and how it correlates with the crime decline, but because of what these people do. They engage in prevention. These are the people who interact directly with the young people who are at the greatest risk of violence and victimization. And their work is about creating opportunities and reducing risk conditions, which we've just heard for the last hour are the fundamental principles of prevention. This just shows you the magnitude of the decline in local government employment, huge decline over 3 months, steady growth. And you might say, well, how does this growth align with the decline in crime and homicide? I've blown this up. This is not meant to be causal. This is just meant to give you a sense of how these two trends move together. The red line is homicide. The blue line is local government employment. And the time period is 2018, right before the pandemic, to today. And what you see is that these two trends are absolutely mirrors of each other. And what we take away from that is, as local government employees, these teachers and counselors and clinicians and grants managers were removed from their jobs at that same time, homicide spikes. As those jobs come back online and those people go back into those jobs, homicide declines. And when you look at the homicide numbers now and the crime numbers in general in all 9 categories, they are well below where they were at the beginning of the pandemic. And not coincidentally, we're at all-time highs for the number of local government employees. Those numbers are also well above where they were when the pandemic started. And so finally, let me just say, okay, that I can see why all of these local government jobs might affect crime, but if they affect crime in this sort of indirect manner because we have more employees doing these prevention-like activities, shouldn't they affect other important risks like drug use? And in fact, they appear to do that as well. So this is CDC Wonder data, and it is the number of overdose deaths reported in a series that begins in January 2015 and continues into the early fall of last year. And what you see is a very similar pattern, huge increase in drug overdose deaths that begin during the pandemic, that peak in 22 and 23. And when you see these local government jobs, these people engaging in sort of classic prevention-like activities come online in 23, 24, and 25, the number of overdose deaths decline, and we are now about 30% below the pandemic peak in terms of the number of annual overdose deaths. So really appreciate the opportunity to speak to everybody and to be here today, and happy to answer questions.
Fantastic. That was great. So I thank everybody for their amazing presentations that were so incredibly informative. There are a number of questions yet to be addressed in the Q&A. Some of them have been addressed through writing by the speakers. So if you all would stay put for a little bit, we're going to just read to you some of the questions in the chat and see if you can respond. So I'm trying to determine, I believe this was in response to Dr. Graham's presentation. Great information, you're preaching to the choir. How do we get federal and state policy changes? Comparing how much funding has gone to funding harm reduction, which is important but not proportional to the opportunity of more upstream efforts.
That is the $1 million question. I think there are two things that we've thought about with respect to prevention, which is there was promise and now I'm a little concerned, but really, how do we use Medicaid to pay for prevention services? And in that context, it could cover things that are both selected and indicated. If you can have codes, the challenge, of course, is paying for primary prevention because you can't develop codes. The second response is really this is where local advocacy it needs to be reimagined, because until we do a better job of making the case for prevention, particularly using folks like John, who's an economist, around this saves money over time. As a society, we are much more willing to pay for treatment as much more expensive than preventing things from happening. And really, so I think that's a really kind of a language cultural shift that we all have to get better. And so this is why groups like NPSC and ASDN are becoming more valuable if we can do a better job of connecting with local practitioners. So I would say part of this is that we have to do a fundamentally better job of researchers connecting with local practitioners to make the case for prevention, and really demanding the importance of moving upstream, because that the return on investment far exceeds anything we ever achieve with treatment alone. And I think data like that John just showed, and some of the other presentations you saw today, begin to make that case. But we've got to do a better job telling the story, or tell our story differently. And if we can, I mean, that really leads to better funding. It's all about storytelling for me. And I think when, politicians often move and do things differently when there's a different story or it impacts them differently, we've got to figure out how to do a better job of making that case.
Very good. Yeah. Anybody else want to comment on that?
I just want to reinforce that.
Yeah.
And I think that's why I think the community level is really important in getting that message to our communities. And I know it's difficult, but we have to train our prevention practitioners to do a better job of doing that. I know I teach, we do training in lots of different things in prevention science to prevention practitioners. And we have a course on monitoring and evaluation, and and yet the monitoring piece we emphasize is really important, because what information can you provide your community about what you're doing? I think a lot of the things that we do, for instance, in schools, is sort of accepted that it's there, and people don't think much about it. But has been shown by Nate and Phil and Linda, that information is really important, that we're making that difference. We're giving these kids skills when they need them for their normal development and enhancing their development. So I don't know how we get that message out strongly, but we really need to. I see it more the community level, and that should drive the state and national, as far as I can see.
Yeah. Yeah. And so I'm going to ask another question from our very own Robin Jenkins. I can't ignore that one. So he'd like to know how these interconnected strategies leverage each other. We can often measure systems and community change. However, we don't seem to have a strong literature on the core components with and across such strategies, the connective tissue between and among them, stable and sustained leadership and champions at all levels, infrastructure that promotes and sustains are critical. So I'll stop there because it's a mouthful, but anybody want to take that on? Okay, we might have to go offline with Robin.
No, I think that's an important point. We really haven't to do. I mean, as a researcher, you look at that and think, oh my gosh, how do you do that? I mean, our community-based studies sort of have done that with like Prosper, for instance, which integrates strengthening family and life skills training, and they show long-term outcomes. But we don't have a lot of those studies in place. Communities That Care has some of that. I don't know, Nate, Bill, are you aware of other kinds of studies like that? But I really think that's a really terrific question.
Nate, did you?
Well, I think, yeah, sure. I think that, well, I know that the infrastructure is going to be able to set the context for evidence-based programs to be successful. And I think one of the real leading edges, one of the really important current challenges with prevention is cultivating a really strong prevention, national, state, regional prevention system that includes this support, that includes a well-trained prevention workforce. We have we have so many invested individuals in so many different prevention systems that are doing such great prevention work that could probably be doing even better work if there were more prevention education programs, and if there were more certified prevention specialists. I think the last time we counted those, the number of those folks in Colorado, there were maybe 55 to 60 certified prevention specialists. So yes, I think that just to kind of reiterate what I was saying, I think that is really one of the current, should be one, in my opinion, one of the current priorities in helping to cultivate a more robust prevention system and prevention infrastructure.
Yeah, good. Yeah, that's what it's all about. So I'm going to ask a question for Dr. Roman, and then I have a question for Dr. Richter. So, Dr. Roman, what other factors could explain a decrease in crime and violence?
So that's the $1 million question, right? So essentially what we do in most of these studies is we say, what is the effect of this new curriculum or something? And we set up a little experiment and we test it sort of going forward. Here, what we're trying to do is to say this thing happened, what could have been the cause of it? And there's all kinds of explanations for it. Really, when we set out to look at this, it could be changes in policing. It could be changes in police legitimacy after George Floyd's murder. It could be changes in the number of guns that are owned in society. There's any number of other explanations. what we try to do is to set out and find explanations that explain both the spike in overdoses and in crime, and also explain the decline, that they're symmetrical. And when you think about it, and things that change, because we think of a lot of structural factors matter enormously too. But not those things didn't tend to change much, and most of the other explanations can explain either the peak or the trough, but not both. And what's left here is, about the best you can hope to do with this kind of research is to look at every plausible explanation you can think of, test it, and see what stands up to that scrutiny. So far, what has stood up is this idea. There are other takes on this. Center for American Progress, Brookings, have both sort of looked at particularly on the effects of all of this funding on the schoolroom and what it's meant for chronic truancy and for teachers, and have some interesting ideas there. But I think what we're just trying to say is this umbrella came, shielded everybody from the rain for a little bit, helps to explain all kinds of new investments in, community health, community violence intervention, all these different things came out of this same bucket. And what they all share in common is the attribute that they're prevention, that they're not last thing I'll say, I'm sorry, but when you look at like Mayor Scott in Baltimore was asked this about why he thought that crime had declined in Baltimore, which had been impervious to prior crime declines. And he said, look, we spent, $30 million on this crime prevention activity, but we spent $50 million improving the parks and community centers, and $100 million on community health, and $150 million on this other thing, and it all matters. And this idea that the only way to improve criminal justice outcomes is to do things within the criminal justice system is just not true. And that's really the message that I want people to take away from this presentation.
Yeah. It's really excellent evidence-based observations that I think should be directing policy, and that kind of segues a little bit with what a little bit of a shift though, but it segues with a question for Dr. Richter, just with respect to trends in marijuana use that we're seeing across the country in states that have legalized recreational cannabis. And oftentimes what we see is that our public policies are very inconsistent with the science. And I think we see that to a great extent with what's happening with legalization. And given that this is a policy-oriented briefing series, I wonder if you could just speak to that briefly.
Sure. Thank you, Denny. That's a topic close to my heart, and we've worked on it together a bit. So I think this is a little bit of a unique case in that the marijuana legalization occurred for various reasons in all the states. And I think that the perspective on the effects on youth kind of was not top of mind as it should have been. And so there were, racial equity issues that were very valid. There was decriminalization that was very valid. There was medicinal use valid considerations, but sort of the youth component was not considered as it should have been. And our organization did a very thorough review of state legalization laws and regulations, and kind of, documented the youth protective provisions, and they're very inadequate for the most part, some states better than others. But what we have been seeing more recently is as legalization has pervaded the country, and there's more and more kids using and exposed, especially to the illegal versions of these products that are the hemp-derived intoxicating products. The public is waking up to these consequences, as is the research, has finally started catching up, no longer just being based on what the quality and potency of marijuana products were in the 80s and 90s, but more currently. And what we are seeing are some real significant consequences to young people's health, physical and mental health, and future outcomes, cannabis use disorder included. So what we're tracking and noticing is more interest now in focusing on the youth protections within these laws and regulations, and really hoping that more states will pay closer attention to that if they are legalizing, whether it is revising their current regulations and provisions, or if they have not yet legalized but are considering doing so, really prioritizing the youth in terms of their health and safety.
Yeah. It's lessons to be learned. Unfortunately,
lessons that are never learned
the hard way, right?
Yeah, exactly.
Right. And the question is, to what extent is this information, getting back to policymakers. They can make adjustments to previous decisions. And yeah. So I guess we should have time for at least one more question. I'm looking at this from Kara. Is anyone interested in studying the intersection of public health prevention? Oh, I'm sorry, Phil. You wanted to say something else about Linda's topic?
Oh, no, I didn't mean to raise my hand. That's AI
Oh,
getting
okay.
in the way. I
Oh,
apologize. Keep going.
okay.
I'm
Yeah,
lowering it.
sometimes if you go like this,
Yeah,
AI
so yeah,
all of a
sorry.
sudden bubbles and balloons and okay. So studying the intersection between public health prevention, health equity, and restorative transformative justice, how restorative justice is a powerful public health strategy for prevention, intervention, and recovery. Would anybody like to take that on? Not silly. Philip, I think you came close to it in your talk.
Yeah, so I don't know specifically. I think maybe the public health and restorative justice piece, but I have to think. Yeah, well, I take that back. Look at the work of the Prevention Institute. They do amazing work in this space, and it's done through a community-led lens, and so they're being one of the champions of really integrating prevention science and on the ground community work. So I would say take a look at their website. You should find some informative information there.
Oh, great. Okay. At least we can provide those kinds of resources as well, and we'll try to amass some when we send out the recording. An observation was made that there wasn't a lot of focus on fentanyl, which of course is one of our big crisis right now. Interestingly, with fentanyl, the pathway to fentanyl abuse, sometimes overdose and sometimes death, is not traditional. It's not a traditional pathway with risk and protective factors involved and contexts and so forth. Sometimes just strictly accidental, right? They didn't mean to take fentanyl. They didn't know what it was going to do. They didn't realize that they were even taking it. They don't, et cetera. And that some of the most horrific deaths have occurred that way. And so there are a number of people that are studying those trajectories to fentanyl use and the protections and way, the harm reduction methods that can be used to ensure that people don't overdose and potentially die as a result of accidental use or intentional, right? So there are a lot of different kinds of strategies that I think are called for to deal with fentanyl that are not traditional scientific lines of inquiry, but that are now being looked into, especially from a policy perspective. So I appreciate that comment. A few more questions, but I think we're just about out of time. Does anybody want to say anything else in closing? I personally think the Q&A is the most fun part of these briefings. I think we get a lot of really rich information that the audience is really concerned with. So this has been
Danny,
great.
will we answer the remaining questions and send that out to attendees, or how does that work?
With the remaining questions, we can
Yes.
certainly do that. And if they're still on, I mean, if you want to stay, you can continue to answer questions.
Well, I mean, some are
I'm
just
happy
fascinating. I'm
to.
not sure I can answer them, but I do want to make sure if there's a mechanism
Yeah,
for someone to answer, and that might be something
yeah,
that's forthcoming to the
yeah.
great
I
extent we
do.
can.
Yeah, I
I
do
took
hate to
a
ignore anything.
I took a
Paige?
list of all of the comments and questions that were directed for all of the speakers, so I can send you guys a list of that so you
Oh, so
can
great.
answer them, and we can send those off with the webinar updates and things like that.
Oh, that's so great. Thank you. I appreciate that, Paige. Yeah, and Brian Baumbarger just asked a question, which is another one of our colleagues that we try not to ignore. So I don't know. Should I ask it? Are you all game for 2 more minutes? It's another long one.
Go for it.
the fundamental building block that was the genesis of all the great impact Pennsylvania saw through the communities that care and the evidence-based programs, was detailed community level risk and protective factor data packaged and provided to communities in an actionable form. In the decades since I, meaning Brian, left Pennsylvania trying to replicate what PA did, the universal barrier everywhere has been the lack of data infrastructure. This could be an incredibly helpful federal investment. And in an era where we are losing access to federally sponsored data, this is a concern that we won't be able to track these outcomes. We won't know the consequences of policies that are being rolled out, and communities won't know how to refine and adapt their strategies to address prevailing issues. And so data infrastructure is one of the most important, potentially a threat that we're looking at now, but also one of the most important parts of the infrastructure to respond effectively to the substance use crisis in the United States. So now that I've been a blowhard here, what else you got, Bill?
Well, two things. One, I think the FORE Foundation and
Yes.
also Robert Wood Johnson,
Yes.
I think everyone recognizes, the threat to losing federal data sources, but also recognizing this needs to be local. And so I do think there are efforts that are currently looking at what that data infrastructure is and moving more to a local regional level where that data is more actionable. So out of some of the chaos, I do think that there has now been a recognition that we need to do a better job of that. And so organizations like Big City Health Coalitions and also ASTO are really leaning in to understanding ways in which to improve local data for local problem solving.
Right.
And this
Excellent.
gets back to our framework, Denny.
Yeah.
The National Prevention Service releasing is data informed by data. So
Yeah, absolutely.
it's a nice question to end on, I think.
Yeah, it is. It is. So it's a very important issue. And I'm just writing in the chat. People are inquiring. Oh, they want slides. They want more information. That will come in about a week. You'll get everybody who's registered will get a link to the recording and a copy of the slides and any resources that we have to share. So I really thank all of the speakers for amazing talks and putting your brains into such important issues. Thank you, Paige, for beautifully moderating. Thank you, Jess, for helping me coordinate all of this. And thank you to the audience for hanging in there and being very interested in this important topic. So hopefully we'll see you at the next briefing. Take care, everybody.
Thank
Take
you,
care, everyone.
Jenny.
Bye.